moving right along, I have the great honor of introducing our next speaker, Patricia Murray, from the Department of Health and Wellness. Patricia received her BA degree from Mount Allison University in 1980. She returned to school to complete training to become a psychologist and earned a master's degree in applied clinical psychology from Memorial University of Newfoundland in 1988. She received her master's degree in health services administration from Dalhousie University in 2008. She practiced as a child psychologist in Drumheller, Alberta, and in Antigonish and Bridgewater, Nova Scotia. In 1998, she joined the mental health program at the IWK Health Centre as team leader for the Central Referral Service. In 1999, she assumed the position of Health Services Manager, and then in July 2004 was appointed Director of Ambulatory Services within the Mental Health Program at the IWK, responsible for central referral, 3 community mental health clinics, maritime psychiatry, the crisis team, and the child and adolescent day treatment programs. In January of 2005, she was seconded to the Department of Health to project manage the new $4 million autism initiative. In September 2006, she became the Director of Children's Services with the department, responsible for child and youth mental health for forensic youth, autism, youth at high risk, and complex care children. She assumed the acting executive director role of the Mental Health, Children's Services, and Addiction Treatment Branch in July 2010. She was appointed Special Advisor to the Associate Deputy Minister on Mental Health and Addictions in 2011. In this role, her primary responsibility is to implement the mental health and addiction strategy for Nova Scotia. She is a strong advocate for enhancing services for those living with mental illness and problematic substance use. Throughout her career, she has had the privilege of working with children, youth, and adults with lived experience, their families, mental health and addictions professionals, district health authorities, IWK leadership, and colleagues in several government departments to champion the mental health and addictions agenda. So please welcome Patricia Murray.
Well, good afternoon, everyone. Thank you very much, Roy. It's my great delight to be here today. And I will say that I don't have a PowerPoint presentation. I'm going fairly basic. I do have a copy of the strategy, which I take with me everywhere. The back page is what I focus on because that is our plan. And so I just thought I'd have kind of a conversation with you today to talk a little bit about how the strategy came to be and then where we are with our progress moving forward. I'd like to thank these gentlemen who are signing for us today. I tend to speak quickly at the best of times and really fast when I'm excited, so I will try my best to keep it at a reasonable rate so you can manage. I want to thank the Coalition for putting this event together and for inviting me to be here. I'm really thrilled to be here. I think that the last event that they hosted was in the spring, and Terry Taylor was here talking about the process that the Nova Scotia Health Research Foundation and the Mental Health and Addictions Advisory Committee Strategy Advisory Committee were going through to provide us with the report come together. So this is kind of an update now on where are we at this point. So I guess you all do know that in 2010, our minister announced, or it was announced through the throne speech, that there would be a mental health and addiction strategy. And I have to say that Steve did an excellent job of laying out all of the needs for mental health. It's a little overwhelming when you hear it all at once, but certainly he did a very good job of describing it. But I am also excited because I think that there's a lot of things that are happening in Nova Scotia, and I think we can feel very good about the fact that we are certainly moving things forward, and we have people working very hard across government departments and across the formal system and beyond, and all of you. So I'm especially delighted to see so many of you here today. You're the ones that really make a huge difference on the ground. And so I hope that as I'm discussing what we're doing, you feel that some action is really taking place and some good things are happening in Nova Scotia. Just to build a little bit on what Steve was talking about, I was in Ottawa a couple of weeks ago as well at that awards ceremony, and there were 6 awards presented, and 3 of them were to people in Nova Scotia. So then it became, well, Nova Scotia cleaned up and Nova Scotia rocks. So I just like to carry on that theme, Steve, because I still think we rock. Anyway, it was very exciting that people can see a small province can really accomplish a lot, and we have a lot of advantages being small. There are disadvantages as well, but we choose to see that we have a lot of good things in being small, and we can make some things happen. So we had a very passionate minister, many of you would know her, the Honourable Maureen MacDonald at the time, when the strategy was announced. And she was very adamant throughout. She wanted a very practical, concrete strategy. She wanted action items that were doable, that we could see progress with, and so that's what you should find on the back of the strategy document you have. It's a bit of a shopping list, and it's not meant to be, but it's a lot of different initiatives that we can put into place to together create quite a robust continuum, and that we do more in the community and address people's needs in a variety of different ways, so that she wanted the mental health and addiction system to actually look different, and I think after we're completed in implementing this strategy, it will in fact look different. So we started with 5 key priority areas, and they're listed there on the back. So the first one was intervening and treating early for better results. So we know, and we're learning more and more all the time about the value and the importance of working with young children, in fact, from infancy on, and even during pregnancy, so that children get off to the very best start possible. And the best way to prevent difficulties down the road is to make sure they get what they need really early on. So our first initiative is to have an 18-month screen done across the province. And I want to make sure people know that that's not sort of a mental health screen. These children are really young, but it's just a developmental screen. So we want to catch kids early, so that if they need any additional assistance, that they can access that prior to starting school, so they're prepared to start school. So that families understand what young children need and how to create the best possible environment for them so that they can thrive and succeed. And so our plan is to have all of the 18-month-olds screened or seen by a primary care practitioner, and have referrals made if need be, to have information provided to families about what resources are available in their own particular communities so that these children get the best support and these families get the best support possible. And what we've done on that so far, we had a large meeting at the 1st of October, and I'm not going to remember the exact title, but it was something about working together for children and families. And it was primary care, it was public health, it was mental health. And there are a lot of people that agree that it's really important that kids get seen early. And so we will proceed with that, working with the primary care practitioners in how we can make that happen. There's a standard tool that we would like them to use. It doesn't take too long to administer. More than a primary care physician can administer it. It could be either a primary practice nurse or a nurse practitioner. So that's what we will work towards, and we will get that started before the end of this fiscal year. And then we wanted to also provide families with younger children with a way to address some of the behavior and anxiety problems that young children have. And so the Strongest Families program that Steve referred to is one that we have had in place at the IWK in the Capital District and in Cape Breton, a little bit in Cumberland. But again, scaling up, we've decided that that should be available to everyone across the province. So we've just signed the MOU with that organization, and we should see between 200 and 300 children this year, and that will be taking them off wait lists from across the province. And so that's a pretty significant chunk of children that would normally be waiting probably a bit of time. They would be considered our regular referrals, and we see our more urgent referrals more quickly. And so in terms of getting them care in a timely manner, this should make a huge difference. And once we address the people that are already on the waiting list, the hope would be, as we move forward, that as children are referred who fit the criteria for this program, that they can receive it right away. So that is a whole piece that is really going to address helping families in a timely manner and not having them wait on wait lists, which is not helpful for anyone. And then we thought school is a place where most kids are, and so we needed to do something more to support children and youth in school. And so through, I'm blanking on the name again, there's a government initiative around kids, and it involves a few things, including Safety Link, but it also involves putting mental health clinicians in schools. And so we have 12.5 FTE positions that will be hired across the province. 2.5 positions will be for the French board, and the other 11.5 will be for the English boards across the province. And those positions are in the process of being hired now. We're hoping that they'll be in place this fall. There's 2 already hired on the South Shore, so they're already up and running in schools. These clinicians will be located in the schools, so they will connect with and be hired by the District Health Authority. And they will have a home team with the Child and Youth Mental Health team within the district, but they will do most of their work in the schools. They have an office there. They will connect with all of the school personnel and provide services there. So they may be able to liaise with teachers for some difficult mental health issues that present themselves in the classroom. They may be able to co-facilitate groups with school personnel and increase the capacity of folks in schools to be able to provide these groups. They could provide some early intervention or some brief solution-focused treatment to kids who have mild to moderate difficulties. And if they recognize that things are more difficult than that they can facilitate the referral into the formal system. So that kids are seen in school if it can be possibly managed in school, and then only those that really need additional assistance are referred into the formal system, which means that will help with the backlog currently that exists in the formal system, and it will also see kids where it's more appropriate to see them. So that's a very exciting initiative that is underway. School policies related to mental health, substance use, and gambling. Now we've changed that to guidelines because we want to look and see what schools are doing around promoting mental health and addiction or appropriate substance use, if that's not the proper word, but just making sure that they build resilience in kids so that they make wise decisions as they get older. And so there's a project going on that the IWK is leading that will also be present in 2 or 3 schools around the province, and they will evaluate how that goes, and then we will be able to broaden that to school boards across the province. And that's a 3-year project that's currently underway. Collaborative care with primary care, so you've mentioned that, and that is very important. That I think is going to be more of a long term. We say this strategy is going to take 5 years, and I think it likely will take 5 years to get this fully implemented, but we will certainly be starting, we've already started with internal conversations about this, who we need to involve, how to engage them. But we do hear a lot of really positive things from primary care folks that they want to take this on as well. We know that a huge number of people are seen by their primary care physician and never get any further, and as you've noted, often they don't get the care that they need. So we want to equip primary care practitioners and professionals with the tools that they need to recognize a mental illness, possibly to provide limited assistance in their practices, and then have a very smooth referral system into the formal system. And that's not currently existing, so we need to work on that, and we're very excited to be working on that. And then educating our EHS paramedics. We know that EHS paramedics run into mental health and addictions issues when they're doing their regular work. They've also recently been placed in collaborative emergency centers and in some long-term care facilities. So the more that they can understand the mental illnesses that they're dealing with and the addictions, the better. So we're hoping to provide some education for them. Providing supporting gay straight alliances in schools. That's another way to support some of our more marginalized youth in a positive way in a school setting, where hopefully they will begin to feel safe. And the Department of Education is actually taking that one on. That's part of their anti-bullying strategy. And so we're holding them a bit accountable for making sure that those things happen. They are already around the province, but they have sent out letters to all of the school boards saying that they strongly urge them to promote these alliances and create even more. So then we wanted to look at shorter waits, better care, because we know that access is an issue, as Steve alluded to. We know it's hard sometimes to know where to go and to get in. So we're introducing a program called CAPA across the province called the Choice and Partnership Approach. And this is much more person-centered and family-centered. So you'll come in for an appointment. It's a 45-minute face-to-face appointment to talk about what's going on And with the conversation that you'll have, it'll be determined how the system may be helpful to you. Someone with the appropriate skills to best address the difficulty that you're presenting with will be assigned to you. And so, again, to get the appropriate care that you need. And so the skill sets of all of the clinicians in the clinics will be determined, and then pairing people up more appropriately is going to happen. And they'll be goal-directed based on the family or the individual's goal, as opposed to what the clinician seems to think should happen. And so hopefully that also meets the needs of individuals and families much more thoroughly. They will focus on maybe 1 or 2 goals at a time, and then they will be off working on those goals, and other people can get into the system. And if they need to access the system again, then they should be able to come back in a timely manner. So we think that that's going to sort of shift the way that community mental health services are offered within the formal system. Peer support, as Steve said, that is critically important. We've been hearing that for a while. I would say the formal system has not always embraced it, but I think we're finally there. So Roy has done an awful lot of work on this, as have others, and many of you are in the room, Vince and Andy and others. And we're really pleased that we're going to be able to introduce, I don't know if we've settled on a number yet, but we will introduce a peer specialist system across the province so that all the HAs have at least one. And I realize that's a small step, but it is something, and it will be province-wide. Hopefully by next summer. We have signed an MOU with the Peer Support Certification Canada, or Accreditation Canada, the SAC. And we will be ensuring that all of the peer support workers that are involved in this program are accredited, so they have very good training and consistent training, and it will be the same as what's offered, across Canada. And then that they will be hired by an organization outside of the DHAs, actually. There'll be an RFP going out for that shortly, to ask for a community organization to actually manage and oversee the peer support group. So we're very excited about that. Skills training and support for families. So that's the merited program and the craft program for the addiction side of things. And I have to say that you'll notice that there's ticks beside these. So some of them are to be initiated this year and then over the next 3 years. But people are so keen and excited that I can hardly keep them at bay. So I've been asked to start addressing some of these things much earlier than we have outlined in this strategy document, which I'm thrilled to do if I can fit that in. And so the merited people are going to be here within the next week or two, and I will be meeting with them to talk about how that will be rolled out across the province. They did, CDHA did get some funding through the Mental Health Foundation of Nova Scotia to ensure that this training does happen across the province. So it's lovely synergies that are happening, and we're really pleased that that will happen. And that program works with families, because we've heard a lot from families that we do not pay nearly enough attention. They don't get the information they need, they don't get the support they need when they're living with a loved one or supporting a loved one with a mental health issue or an addiction, and so we need to do this. And this program has proven very helpful in other jurisdictions, so we're very excited. The opioid replacement treatment, that's a very difficult one to address. The need is huge. We have a small budget, or a budget for that, and there was a large stakeholder group that met the first of this month, and they are now looking at recommendations, and that will come back to inform the department in terms of how we best provide or best spend that money and provide the services to the group of people that really need them. The toll-free crisis line, we do have a mobile mental health team at CDHA. That's a partnership between CDHA, the IWK, EHS, and police, both the HRM police and the RCMP. And part of that is a 24/7 crisis line. And they have a 1-800 now currently, because not all areas in the HRM can access a crisis line without it being long distance. And so they have also received calls from other parts of the province. So again, scaling up, we thought that we could provide this service across the province so that basically any Nova Scotian can have access to a crisis line 24/7. And if a referral needs to be facilitated to an emergency department, that can happen, because connections will have been made and they'll know how that process works. And if they need to be referred for just a follow-up, not just, but a follow-up appointment that's less urgent, then that can be facilitated as well. So again, that expands that service across the province. We're going to look at the location of mental health and addictions beds. That's a next year's task. We do know that it's difficult to recruit and support teams, small teams, all across the province. So we need to take a look at how to best provide those beds when they're needed. And We also have issues around the alternate level of care folks, so those are people that are in beds that should not be in beds. They should be out in the community, and we really have not done a great job of being able to find places for them. So part of the housing piece that Steve talked about is work that's also ongoing. Specialty care networks. We gave the 3 of our currently existing specialty care networks some funding this year to sort of enhance them because they haven't received funding for a long time. That would be our Seniors Mental Health Network, the Eating Disorders Network, and not the Sexually Aggressive Youth, there's one more. Oh, I'm blanking on it. Is it early psychosis? I don't know the early psychosis network yet. Anyway, my apologies, I do blank on some of these things. So we're going to develop more networks because that's an ideal way to provide services in Nova Scotia, given that we're not very big and it's not possible to have specialty teams in all the DHAs, but we do have a lot of specialty folks across the province and within CDHA. So we will set those up for possibly early psychosis, reproductive mental health, concurrent disorders, and I think the options are, possibilities are endless for that. We are looking at concurrent disorder training, so we have 2 folks now hired who are developing the competencies and the training package that will be delivered across the province to those, to all folks working in mental health and addictions, and then a specialized package to those who will be offering treatment for people with both a mental illness and an addiction. Greater awareness of problem gambling helpline. We're going to do some more. We're rebranding the helpline, and we're going to do some more to support that so that it's more readily accessed. One of the challenges we have is that gambling is a huge issue, and it certainly comes with and as a result of mental health issues. But people don't access support as much as we would like, and we need to figure out a way to break down some of those barriers and the stigma to offer the services that are there, because we do certainly have services. Better information systems. So as Steve said, it's difficult to show a change in anything if you're not able to measure it, and we really do not have good measurement systems and good information systems currently. The addiction side has Assist, which is an information system that they do use, and they can get good information out of that. It, however, does not talk to other systems, and the mental health system doesn't have one. So we're currently working with a consultant to figure out what is the best system that might work for both, and that would also talk to other health systems so that we can have information more readily available. We don't have to keep asking consumers questions about, repeating what their story is, because that gets very tiring for them. And they don't like doing it, and fair enough. We should be able to provide a better service. And then overlaying all of that, we have to consider our Aboriginal and diverse communities. As Steve said, we don't do a very good job of serving those folks, and we be no exception in Nova Scotia. So African Nova Scotians and the LGBTI community, and the immigrant community. Now, I'm not sure the immigrant community is very strongly identified in this document, but we are certainly aware that that's a group we need to work with. Disabled persons are not strongly identified in the document. Again, a group that we're going to be working with. So I've met with all of those groups, and we will be having additional meetings to figure out how do we best start to better recognize the needs that they have and the ways that they choose to access services. Now, for our First Nations, we're having a meeting actually just later this week with all of the District Health Authority directors of mental health and the health directors from the First Nations communities, some of the federal folks that work with First Nations and Inuit Health, and with some of our folks at the Department of Health and Wellness. And we're going to work to try and provide clinicians in communities, because we have recognized more recently there's always a jurisdictional issue, and people have talked about that for quite a long time. Saying that it's the federal government's responsibility, and so it isn't part of a service we provide, but in fact the federal government doesn't provide any mental health care, and limited in addiction. So that becomes something that we need to do. These are citizens of Nova Scotia, and they deserve to get care as well. So we are working on a way to better meet their needs, and they have told us that it's better to have someone come into the community rather than to expect them to come out of the community, that we need to consider some of their traditions in terms of providing services, because they hold a lot of value for these individuals, and that needs to be respected. So we have a bit of work to do there, but I think that's going to be very interesting, and there's a lot of enthusiasm around the table for that. Sex, gender, and diversity review of services. So again, going forward, we have to always consider that whatever we introduce, we need to acknowledge all of those specific needs, and we need to always apply that lens so we make sure those needs are being met. Because I would say we have not done a great job of that in the past. And then enhancing the workforce. So we've got, people don't tend to see themselves when they come into a mental health clinic. And so I know we need to figure out a way to encourage young people from any community to take an interest in the mental health profession or in other kinds of supports that will assist those living with a mental illness or an addiction. And so we have to figure out a way to encourage that, and that's one thing that we've identified. More French-speaking professionals, because in some parts of the province, there are certainly a lot of French-speaking consumers who would like to have their services provided in French, and we continue to work at trying to do that. Education on seniors' mental health. So there was a time when people sort of lived and died in the Nova Scotia hospital, but that's no longer the case. However, we have not provided the adequate support of the community so that people who are looking after these folks actually know how to do that well. And so I think we're doing the people who work in long-term care a disservice by not providing that kind of training and support once they receive the training. And certainly people aren't getting the adequate care they need in the community, either in a long-term care setting or if they're living at home, or home care. So I'm actually speaking about 3 or 4 times this month to long-term care providers from across the province to start talking about what that training might look like and what kinds of things they need. Safe and affordable housing, as Steve alluded, we certainly do need that. We're working with the community services around that. We have a group together called the Continuing Care Services for Disabilities Group, and they're looking at some of the complexities around the services that both groups provide. There's a little bit of overlap, and there's some that absolutely fall through the cracks. So we need to come up with a better, smoother, broader continuum of services. I do know that they were doing a bit of a housing first pilot by putting housing support workers into shelters and trying to provide homeless people with homes. And this was just in the Halifax region, but it's at least a start. And I believe they placed about 250 people, and now they've made those positions permanent. So that's very good to see. I would say that we have a lot of support across government and at the most senior levels. The Department of Community Services and Justice and Education and Labor and Advanced Education and ourselves, Health and Wellness. There's a lot of shared interest in the room because we know that it isn't just a health and wellness issue. It certainly is much broader than that. And as Steve alluded to, the Hyde inquiry, Ann Derrick did an exceptional job on that report. And it is a very good read, and half of the recommendations, of the 80 recommendations she made, were around health. So we've been working away at that as well, and we've been providing some training to the justice system so that they better understand people living with a mental illness or an addiction and how to best work with them and interact with them. And that's happened throughout the province over the last couple of weeks, that training. And we also have identified in our strategy that we did hear there isn't enough there aren't enough treatment services provided in the facilities across the province. We have the East Coast Forensic Hospital here. That doesn't help anyone who is in another facility elsewhere. And so I know that they do transfer people to Halifax if the need is great, but for some, they wouldn't need to be transferred to a hospital, but they still have mental health issues. So those need to be addressed where they are, and we need to work harder at doing that. But the Hyde inquiry was a very positive piece of work that assisted government in figuring out how they could move forward in working with the justice system. And I'm talking to about 3 other groups about our strategy for the justice system this month as well, in addition to the training that's gone on. So lots of people really want to hear what's going on and want to know how they can help make all of this happen. We need to have better information, especially on the addiction side, because you know that we hear a lot about deaths that happen as a result of overdoses and drug addictions. And we don't have very good information to tell us is that accurate. And so we need better surveillance on that, and we're going to be able to beef up the information we have so we can make better program decisions. And then finally, stigma. And stigma ended up as the 5th priority, but it could have easily been the 1st because, frankly, unless you address stigma, you're not going to get anywhere with anything else. And so that's very key, and we are working with the Commission on a couple of anti-stigma initiatives. And we're looking within Nova Scotia to see what else is going on here that we could promote. We have been providing the mental health first aid across the province. One of my colleagues, Tony Cron's, did an amazing amount of teaching on that. And we have certainly people trained in every district. And even outside of the health system, there's been a lot of interest in other organizations to have folks trained. So that's something that we will certainly continue to promote. And this is Workforce Month. And as I think Susan announced, there is an event at 5 o'clock about the psychologically safe workplace standard that's being introduced. And we were anticipating that coming out, and so we're going to work with that into next year to figure out how we can promote psychologically safe workplaces, because we know that certainly many adults, most adults spend a good chunk of their time in the workplace, and if that's a bullying environment or a toxic environment or somehow an unsafe environment, that's not good for anyone. So we need to make sure people are practicing good psychologically safe things in the workplace. And then we were going to work with the press, because we know that things get out into the media. We tend to make it into the media only for negative things. They usually are, really the exception to the rule. Most people living with a mental illness are not violent, but those are the ones that seem to get reported. So there are guidelines that the Canadian Psychiatric Association have developed, and we've provided them to our press folks in Nova Scotia before, but I think we have to actually have a conversation to help them better understand the role that they can play in being a positive force for mental health and not just reporting sort of the negative stories. So I will just a little bit more on how we're working with the Commission, because I have the privilege of being part of the Provincial Territorial Reference Group that met for, I was involved for about 3 years, that met to help put together their national strategy, because it was very important, as Steve has alluded to ensure that they were in line with work that was going on within the provinces, because they weren't given any funding. So the only way that strategy is getting legs is if the provinces take it on, and we're very keen to take it on, because it does align with what we've been saying as well, and so it gives us a little bit more oomph when we can say that this is also consistent with the national strategy. So there, you said in more detail, but just quickly: promotion, prevention, recovery and rights, access to services, disparity and diversity, First Nations, Inuit and Métis, leadership and collaboration. So ours are intervening and treating early for better results, with a focus on children and youth, shorter waits, better care, that's about access, Aboriginal and diverse communities, working together differently, that's about leadership, that's about cross-government, and reducing stigma. So I think there's a lot of alignment just in terms of their key priority areas and ours. So we are working with them on stigma. There's 2 programs that we're just learning about now. One is the Physician Support Program out of BC, which has produced excellent results. It better enables physicians to provide more appropriate care. It has reduced the number of prescriptions being given out, and it increases the connection that the physician makes with the person and provides some supports while they're actually in the office. And so we're looking into that, and we're also looking into one that was developed through the Department of National Defense, interestingly enough, for leadership to be more aware in the workplace about how stress affects people and how to make sure that it is a psychologically safe workplace. So we have a couple of those things that we're very excited to get underway. We're also working with the peer support, as I mentioned earlier. And the Provincial Territorial Reference Group just met after the leader group met and after those wonderful awards. So I was kind of gloating all the way through our meetings to say that Nova Scotia rocked, but anyway, we got a little tired of hearing about it. So we had to decide, so now what is our role? If we met before to kind of help put the strategy together, well, their strategy is out, ours was out a week later, so where to from here? And we decided as a group that there were 3 or 4 areas that we should focus on, one of them being recovery. So recovery is a word that appears in our strategy. Again, it wasn't a common term used in mental health in particular. And it's not just saying, yes, we believe in recovery. It really is shifting a whole culture. And so that's not going to be a quick thing either, but that's going to be something that we will continue to work on. And some of these other programs that we're putting in place will actually support that. And so we hope to see that happen, because that's key. Working with primary care, that was another key priority that we thought as a cross-Canada group that we could also focus on, because we all saw that as keenly important. And a focus on promotion, prevention, and children and youth is one that we will be also discussing further. Because with children, we know that 70% of illnesses start before the age of 25, 50% start before the age of 14. And we also know a lot about the early years, as I was alluding to earlier, through Fraser Mustard's work and the work of the Wallace and Margaret McCain Foundation. And so we need to take advantage of all of that and make sure we make the most of it. So it's important that there always be a focus on children and youth. And then the last one was on good information and good data. So we really struggle in Nova Scotia, so I'm keen to see what we can do nationally in terms of coming up with some standard indicators and then ways of collecting those. So I think I've gone on long enough. I thank you very much for your attention. You've listened very well. I can see people getting a bit fidgety because I think there's food and other things over there. So I will not keep you from that, but I think we'll have a chance for questions afterwards. Thank you again very much. It's my pleasure.